Piriformis syndrome, the third, November 14th, 2024. Currently, we're going to focus on what's called integrated neuromuscular inhibition technique that we will explain a little bit later, look into it a little bit deeper later. So the key points to take home here, I'm going to reiterate some of the facts that we already aware of. Piriformis syndrome, again, is a neuromuscular condition in which the sciatic nerve is compressed by the piriformis muscle that runs down diagonally in the buttocks region. This results in buttocks and hip pain that may also be accompanied by neurological deficit distally. So down further, there may be numbness, paresthesia, hyperesthesia, or even muscle weakness, especially when the syndrome is untreated for a long time, either due to misdiagnosis or just neglect. And then we're also going to mention what's called muscle energy theory. It's basically a physical intervention that uses the patient's own muscle energy in the form of contraction to counter the pathology in that muscle. There's also what's called positional release techniques. Basically, it's a physical intervention that utilizes manipulation of the tissue to counter the pathology. So if I have to summarize it a little bit simpler, muscle energy theory means we are using the patient's own muscle to work against the pathology, and the positional release techniques is mainly us manipulating the tissue of interest to cause a release of tension in the muscle or the tissue of interest. And then there is what's called integrated neuromuscular inhibitory techniques. It's a combination of MET and PRT. And this utilizes both methods done in a coordinated manner so that it provides benefit that is better than either one of the components done alone. However, it is very important to communicate with the patient that there may be transient increase in pain that is self-limited, meaning it lasts up to 30 minutes after this pain arises. After every session of physical intervention, it's very common, but it is transient, self-limiting, so it should not be misinterpreted as a warning sign or a red flag because it is a physiologic tissue response to physical intervention. Again, piriformis syndrome is a constellation of symptoms that results from sciatic nerve being compressed by the piriform muscle, and this manifestation may overlap with other abnormalities such as lumbar disc herniation that causes nerve root pathology, that is radiculopathy, or a stenosis or narrowing of the canal from which nerve root passes through, therefore causing radiculopathy as well. This commonly leads to misdiagnosis and thus the delay or poorly treated of piriformis syndrome. When piriformis syndrome is untreated for a long time, it may result in further damage to the neuron and thus causes chronic somatic dysfunction and changes that may include the pain to persist, paresthesia, or increased sensitivity to pain, meaning things that normally don't cause pain, they start causing pain. That is hyperesthesia. And also muscle weakness, which is possible to happen when the nerve supplying the muscle suffers some damage. Roughly, out of all sciatica patients, 6.25% have piriformis syndrome. In most of these cases, sciatic neuritis is present. Therefore, the treatment is aimed to lower the inflammation in the neuron and symptomatic relief. The treatments include osteopathic manipulation, which what we're going to discuss later falls into this category, and also physical rehabilitation, and also pharmacological intervention that does not involve invasive maneuvers, and then injection, which is a pharmacological intervention but is invasive. After all these options are exhausted, even though they have been appropriately performed, surgical decompression can then be considered when conservative treatment fails. However, currently there is no optimal treatment known for all cases. So which treatment is best? There has been no validation about that. So again, it is very important to communicate with the patient that transient pain increase is very common after any physical intervention. However, this is self-limiting up to 30 minutes after the pain arises. PRT, Positional Release Technique, it involves identifying the trigger point, that is the point of the piriformis muscle where pain is maximally elicited. So the most painful point in the piriform muscle. How do you do this? You basically map out the trajectory of the piriform muscle. This is something that can be done in several different ways, but usually you draw an imaginary line between the inferior lateral edge of the sacrum, that is the bone just above the tailbone, and then you connect that edge, that inferior lateral edge of the sacrum, so the lower outer edge of the sacrum, to the greater trochanter of the femur, that is the protrusion that you can palpate, that you can feel under the skin of the hip of the patient. You connect those two locations and then you put a middle point between those two locations. And that would be the starting point for you to palpate for piriformis muscle. And along those trajectory, you would then identify which point across that trajectory is most painful for the patient. However, be sure to not elicit too much pain here. Be sure to just elicit enough pain for the pain to be felt, not reaching a point where the pain becomes intolerable. Once you identify this point, you apply what's called ischemic compression. Ischemic compression is compression that is applied to produce ischemia locally, so that this in turn will cause the body to compensate by improving blood flow to that region. This also causes theoretically what's called a spinal reflex mechanism, which causes the tissue to reduce the incoming pain input, so it senses pain less. This is theoretically be the reason why ischemic compression actually succeeds in reducing pain. It is thought that ischemic compression, 1, improves blood flow locally, 2, it causes spinal reflex mechanism. The spine reduces the pain input from that area. So after the procedure, there is a pain relief. Sometimes it is sustained, especially when it is performed repeatedly over weeks. INIT is integrated neuromuscular inhibition technique. It employs a combination of PRT and MET done in a coordinated way to provide benefit that is better than either of them done alone. And MET itself is thought to produce muscle relaxation and lengthening because the Golgi apparatus, the Golgi tendon organs in the muscle belly, they react to prolonged isometric contractions, meaning contraction of the muscle without change in length of the muscle for prolonged periods of time, meaning there's a contraction but there's no movement in the limb. So how do you achieve this? Basically, you contract the muscle, the patient contracts the muscle, but you held down the associated limbs, the limbs that are supposed to move with that contraction, you hold them so that they don't move. That will give you an isometric contraction, and do it for a prolonged periods of time. It will sensitize the Golgi tendon organ, and after you stop the contraction, it will produce relaxation and lengthening of the muscle. And this leads to decrease in muscle tone, which is one of the possible causes that we know of to cause piriformis syndrome, where the piriform muscle is tense or high tone and causes compression on the sciatic nerve. In the study that we're discussing currently, they use a diagnostic criteria for piriformis syndrome that include leg or buttocks pain in the absence of spinal pathology, and there is a unilateral buttocks pain, so this pain is only on one side, and radiculopathy can also be present, that is a result of sciatic nerve compression or the piriformis spasm, which is the underlying cause of the compression itself. This radiculopathy can manifest in the form of, again, numbness, paresthesia, hyperesthesia, or even muscle weakness when it's been chronic and untreated. The buttocks pain is generally aggravated by sitting, and external tenderness, meaning there is a tender point, a point where it is painful when you put pressure on it, near the greater sciatic notch, and pain with tests that are supposed to elicit piriformis syndrome pain, such as Freiberg test, Pace test, BD test, Fear test, and there is a limitation in the range of motion in straight leg raise. So basically, there is an impairment in LASIK test. LASIK is straight leg raise. And things that can confound this condition include any pathology, recent injury of the hip, sacroiliac joint, that is the joint between the sacrum and the majority pelvic bony floor, that is the coxal bone, or the lumbar spine itself. Limb length discrepancy, as we have known, this is a risk factor for piriformis syndrome itself. And this can confound the finding because this also points to the possibility of other muscles being tense as the cause of the buttocks pain instead of just the piriformis syndrome. That's why this falls into the confounder, even though it's a risk factor. Recent buttocks trauma that is accompanied with bladder or bowel dysfunction. This points to the possibility of coda equina syndrome, let's say, or other trauma to the nerve and the surrounding structures, including the hip, the lumbar spine, the sacroiliac joint. So it's similar to the first point. Deep gluteal syndrome is basically sciatic nerve compression in the deep gluteal space, which may not be caused by piriform muscle compression. Extrapelvic compression of the sciatic nerve or the sacral plexus, and these include a variety of conditions that is not caused by the piriform muscle itself, such as gemmelli obturator internal syndrome. It's compression of the sciatic nerve by the gemmelli obturator internal muscle. Pudendal nerve compression. The nerve being compressed, obviously, is the pudendal nerve. And increased mechanical stress on the innominate bone, meaning innominate bone is bone that is extra, or it's not normally there. It's an extra bone. It is an anatomical variation. It is present in some people and it is absent in some people. It's an accessory bone. Compression of the fibular branch or peroneal branch of the sciatic nerve is also a confounder, obviously, because it is basically a sciatic nerve compression, but it's not entirely, because it only occurs in the fibular branch, and of course the symptoms only present in the fibular distribution of the sciatic nerve. So it may confuse the diagnosis of piriformis syndrome because only the fibular branch is compressed. And then inflammation of the bursae of the ischiogluteal or ischiofemoral joints, and inflammation of the hamstrings tendon, hamstrings that is located on the posterior thigh. It may easily be confused with piriform syndrome. And then referred pain from non-musculoskeletal tissue, such as from the gastrointestinal or the pelvic, such as pathologies involving neoplasm, colon cancer, endometriosis, or infection or inflammation such as cystitis. The outcome parameters that are implemented in the study that we're discussing include pain, sciatica itself, functional mobility, quality of life, hip abduction, and hip internal rotation. And the pain is measured with what's called visual analog scale. It basically represents a scale of 0 to 10 that is determined based on the patient's expression upon experiencing the pain to quantify how painful is their condition. Sciatica itself is measured with sciatica Bothersnum index. and a change of 6.5 points is considered a significant change. Functional mobility, this is measured using timed up and go test. This is a test where the patient is seated in a high back armchair, and then once instructed to go, a stopwatch is then started, and then they are told to lift themselves from the chair, to stand up with their arms against the chair, and then they walk 3 meters forward and then back to the seated position, and all of it is recorded in stopwatch. So it measures their ambulatory function. How fast can they do that? Quality of life, it's a scale of 0 to 100. The more the better. This is using short form health survey or SF36 questionnaire. The hip abduction itself, it uses a simple goniometer with 360-degree coverage of 1 degree scales. Patient is in supine position. The contralateral leg, that is the leg that is not being assessed, is dangling off as an anchor so that the pelvis doesn't move around when it is being assessed. So the contralateral leg, as you can see in the picture, the left leg in this case is anchored to the ground of the exam table so that the pelvis is anchored. It doesn't move around. And to place the goniometer is placed, its stationary arm is placed parallel on top of the line connecting the two anterior superior iliac spine. Anterior superior iliac spine are the protrusions on the upper left of your pelvis bone, just above your hip, and then you go up and outside, and you will notice a prominent bony protrusion that is the anterior superior iliac spine. So it's over here and it's over here. You draw a line. This blue line would be the line connecting the two ACs, anterior superior iliac spine, and you put the fulcrum over one of the ACs of the anterior superior iliac spine as the point to put the fulcrum of the ruler of this goniometer. And the static arm is put above the blue line, and this arm that is movable, the movable arm of the goniometer, you put it on top of the midline of the femur, of the thigh, facing the apex of the patella of the knee. And this degree would be the hip abduction degree. And for the hip internal rotation, it is a bit similar without needing an anchor, and then the patient is flexed at the hip and knee at 90 degrees, so it's basically L-shaped from the side. And then the fulcrum is put on the patellar apex. The stationary arm is put perpendicular, transversally perpendicular to the line connecting, again, the anterior superior iliac spine. So it looks like this. The line between the two superior iliac spine, you draw a perpendicular line downward, and then you project it to the level of the knee. That is where you put this stationary arm. And the movable arm, you put it over the midline of the lower leg. And when you internally rotate the hip, the lower leg will then rotate outward. Therefore, you now get this discrepancy. This discrepancy between the stationary arm and the movable arm would be the internal rotation degree, the range of motion. Now we're going to focus a little bit on the integrated neuromuscular inhibition technique. The positioning of the patient is pronated, so facing the floor on the exam table, and then the affected leg, the leg that we are going to physically intervene, it dangles off with the hip flexed and abducted so that the knee lies on our thigh and we are at the point of view of the therapist. After that, again, you perform deep palpation. So you project an imaginary line connecting the lower outer part of the sacrum and the greater trochanter of the femur. You draw a line and you palpate from the middle point of that line across the trajectory of the piriformis muscle to find out which point is more painful, or most painful in this case. And then after you find that point, you apply what's called ischemic compression. You compress slightly with the pads or the cushioning of your finger instead of the points of your finger, okay? So the padding, the soft part of your fingers, you press that trigger point, that maximum trigger point of the piriformis muscle for 20 to 60 seconds depending on how the patient's perceived pain changes. And this is done for 20 to 60 seconds until the pain or whether the pain is local or is referred, whether it is felt directly on the point of compression or elsewhere while you compress it. Once that pain subsides or gone, you let go of the compression. And during this ischemic compression, be sure to try to find a position that is most comfortable for the patient, meaning the position that reduces the pain during the compression. And this adjustment is performed by the other arm, by your other hand. You try to explore a little bit position that is most comfortable for the patient. After you perform the ischemic compression, we proceed to the resisted isometric contraction. As you might have remembered, isometric contraction here belongs to the MET group. So it belongs to the MET group, the muscle energy theory. How you do this is that you tell the patient to basically try to release its leg from your grasp, meaning you try to tell the patient to contract their entire leg, but only using 20% of their available strength, because there's no way you're going to hold the patient in this position if he uses his full strength, because that is often one hand against an entire leg is just not very mathematically possible. So tell them to use only 20% of their available strength to contract their entire painful leg. So to reduce a contraction, but to prevent any movement of the limb so that you can make it an isometric, you apply resistance with your hand. And do this for 7 to 10 seconds. After that, you can do what's called a RRAF, Reduced Reciprocal Antagonist Facilitation, which is an MET, still a resisted isometric contraction. So it's the same as this one, as tell them to contract their leg and you resist any movement, but it is done in pulse of 2 contraction every second. They may not be able to comprehend you or to follow your instruction very well, especially when, let's say, they are very, very elderly. If that's the case, it's okay to just tell them to contract up to 20 times. So contract, release, contract, release. Ideally, this is performed over 10 seconds, resulting in amounting to 2 contractions per second. But when that is not possible due to communication reasons or other reasons, just aim for 20 contractions, 20 interrupted contractions while you resist movement from their leg. And repeat this protocol until it has elapsed over 10 minutes. So this usually amounts to 3 repetitions, and then you do this clinical exercise twice a week. This would be the video. Let's take a look together. Here now he's positioning the patient so that the knee is on the therapist's thigh. He's now palpating for the piriformis muscle along its trajectory. Sacrum to the greater trochanter. He puts his hand on the middle and he's applying ischemic compression to that dominant trigger point. Now he's going to adjust the leg to the most comfortable position for the patient. In this case, he's performing external rotation passively by opposing the lower leg to the other leg closer to the midline. This produces external rotation of the hip to provide most comfort for the patient. But this is may not be the case for all patients. So you have to readjust. This is a delicate matter that you have to ask the patient whether this provides them more comfort or not. After the pain is reduced drastically, you can let go of the compression. Now, he says that the patient is supposed to remove his leg from the restriction barrier. Restriction barrier here is his resistance. So it's basically telling the patient to perform isometric contraction, to contract their leg while he holds the limb immobile. For 7 to 10 seconds. Now you can see the thigh is contracting. Yeah, muscle energy technique is here, is one of it. After the first MET, you then can introduce the RRAF, the radius reciprocal antagonist intervention. This sort of shows you that it's contracting and relaxing at a frequency of 2 times per second, ideally speaking. So that would be the demonstration of how to perform the integrated neuromuscular inhibition technique. Now, this would be the positional release technique. This positional release technique is what's performed as the other intervention in this study that we're discussing right now as a comparison. How does PRT alone compare to INIT, to INIT? INIT is the one that we just witnessed here. INIT here is again a combination of MET and PRT. How does the outcome compare to patients who only experienced or intervened with PRT alone? And the PRT here is performed with what's called Spiker's protocol. Essentially, the performance is the same to the Chito's protocol, that is the INIT protocol. The INIT protocol that we just looked at earlier is called the Chito's protocol. There are a lot of protocol, and in this study, they use the Chito's protocol. The Chito's protocol is similar to the Spiker's protocol in its starting position. That is, the patient is prone, The knee is positioned on the therapist's thigh, and everything else done up to the ischemic compression. The difference here is that the ischemic compression, instead of being performed for 20 to 60 seconds, this is performed for 2 minutes or until the pain subsides. How do you know the pain subsides? You monitor every 30 seconds by asking the patient whether the pain is reduced. Once that time has elapsed, once that 2 minutes has elapsed or the pain subsides, you can then stop the ischemic compression and then repeat again over 10 minutes for each clinical visit twice a week. As you can see, the initial steps are similar, and then he performs palpation again and then ischemic compression for 2 minutes, and every 30 minutes he asks the patient, every 30 seconds he asks the patient whether the pain was reduced. And you can see he also performs readjustment for the patient's comfort during the compression. Aside from clinical visits, so exercises or physical interventions that is done at the office, the patient also needs to adhere to an exercise regimen to provide pain relief as well as a physical intervention that is able to be done at home. This exercise regimen include piriform stretching and hamstring or calf stretching. The piriform stretching here is performed with the patient supine on a bed or exam table at their home, and they flex both their knees. The painful leg, we're going to delve into it later. The non-painful or the unaffected leg, that side of the leg has its foot flat on the bed, and the painful leg put its foot on the knee of the unpainful leg, of the unaffected leg, and then tell the patient to pull the thigh of the painful leg closer to their chest. This will then cause the hip to flex while in external rotation, and this will stretch the piriform muscle. Tell them to do this, to pull the thigh close to their chest until a tension is felt at the hip or buttocks. After tension is felt, hold that position for 60 seconds. This exercise regimen is first taught in the clinic so that the patient understands, is familiarized so that they can do it again at home. And this should be done over 5 minutes twice a week at least. And for the hamstring or calf stretching, the patient stands up, leaning on a wall with their hands on the wall, and then their unaffected, their unpainful leg is then has its knee flexed forward, and the painful leg is positioned a little bit more to the back, so the knee is extended. So it's like trying to push the wall with the painful leg extended backward and the unpainful or the unaffected leg flexed forward. And this is further advanced where the painful leg is advanced backward and the unpainful leg is further flexed forward until tension is felt in the hamstring muscle at the posterior thigh, at the back of the thigh of the painful leg. After this tension is felt, hold it for 60 seconds. And while the patient is holding this tension position, this hamstring tension position, tell them to swing their body left and right gently so that the hamstring is homogeneously or equally stretched at the sides as well as at the center to ensure a more total stretch of the hamstring belly. This is the result of the INIT and the PRT group. The INIT group, which is the MET plus PRT, and then the PRT alone group. This shows a clinically significant improvement from, first of all, the VAS scale goes from 7 to 2, and from the PRT group goes from 7 to 3.4. Basically, the summary of this, and this one is immediately post-treatment. So once you're done performing this on the exam table, there is an immediate benefit felt, despite the transient increase in pain. There's a definite benefit that is immediately felt in the form of lower pain, improved sciatica symptoms, and faster ambulation, better quality of life. All of this is immediate effect after you've done performing the intervention, and better range of motion in hip abduction, internal rotation. And this one is comparison between the immediate benefit and 4 months after routinely performing this twice a week along with a home exercise. And then in a follow-up 4 months later, there is further improvement. So INIT is superior to PRT alone in improving quality of life, pain, sciatica, ambulation, and range of motion in piriform syndrome, as we can see based on numbers earlier. However, even if the patient is routinely undergoing INIT rehab, it should also be made clear that home exercise is not to be ignored. So home exercise is really helpful to maintain the benefit as well. So this should be emphasized as well, that home exercise is not to be neglected. Thanks for watching.